Another patient came with 3 months neglect. Look at the CT picture. And these patients, if they are walking with a neglected, then the head also gets changes. Actually, he is one of the MLAs of our region who kept on campaigning for the panchayat elections with this fracture. So at 3 months when he came, we excised the head. This is the condition of the head. We gave it the shape and used it to reconstruct the posterior wall. This is the reconstruction of the posterior wall, and then the acetabular component has been fixed. And this is 15 months follow-up. Another patient, 52 years old male. The posterior wall, the fracture of the neck. There is a combination of the posterior wall. So these two indications, we went for a primary THR. He had associated sciatic nerve injury also at the time of initial, but this is 15 months follow-up. There is partial recovery of the sciatic nerve, but still he is using a pro-raising device for the sciatic nerve. Another patient, 52 years old, unstable posterior wall, 2011. Look at the combination. So you should go for even modern investigations to really define the marginal impaction, the amount of combination, because X-rays can be deceptive. So there is a marginal impaction. So if you do a osteosynthesis in this patient, that would definitely go for a THR in the near future only. So we went for a primary THR, and that is the function at 2 years. I have asked her to reduce the weight to increase the life of the hip joint. Another patient, actually this was another message I want to give is, if you are treating acetabular fracture with THR primary or secondary, and you listen here and then you start doing it, before that there should be reasonable expertise of both the surgeries, THR as well as acetabular reconstruction, because otherwise you produce these problems. This was a patient who was referred to us from periphery in 2010. There is a protusio of the acetabular component, and there is an infection, and there is a fracture on this side also, which was not existing preoperatively. So you should have experience for both the surgeries. So we, in the first stage, removed everything, put an antibiotic cement spacer, and then at a second stage, we reconstructed the acetabulum, and she has a rheumatoid arthritis, multiple deformities, but the hip joint is painless now. So in conclusion, we require proper planning for operating either a primary THR or doing a osteosynthesis. Grafting of bone defects with back screws or plate, you can use the head of the femur to graft the defects. Plan the surgical approach through which previous implants can also be removed, but don't use new surgical approaches to remove the implants which are not coming into your way of hip replacement. Treat non-union and then perform THR, and plan primary THR wherever indicated. Thank you.
Any questions?
How long you wait after injury to do the primary THR?
Primary THR we do mostly 5 to 10 days, like osteosynthesis. Once the patient is stable hemodynamically, then we go for primary THR.
You have to reconstruct the column also along with that.
No. In column fractures, I have not included any case of primary THR in acute stage in column fracture. There are some non-unions of the columns where I have reconstructed the column and done the THR. In a primary column fractures, you first do the osteosynthesis. You've seen the example of a 65-year-old male who came to us at 1.5 months late also, but there was bicolumnar fracture. So we did the column fixation, and he again went in full because of the collapse at the fracture site, and then we did the THR.
What about column fractures if they are neglected? Say there's a patient about 4 months old.
If the column fracture is neglected,
head is still inside, so how to proceed in those cases?
if the column fractures are neglected and the patient is young, and you think that there is no marginal impaction and the posterior wall is intact, then I will do open reduction and fix the column fracture.
At 4 months.
Even at 4 months. If it requires surgery, it requires. But if the patient is not able to walk, then you have to.
Thank you. This concludes the session.
I'm treating my patient by using ankle foot orthosis, AFO, which is modified by EVA material. Underlying an ulcer, scooping is done in the EVA, and an offloading metatarsal bar is put, and this works very well in many patients to heal for foot ulcers. So these are my concerns. Dr. Goel.
So last question first about the metatarsal bar and other issues. One thing, when the patient is wearing the footwear, at that time he is offloaded, because wearing the footwear at that time metatarsal bar is working, otherwise it's not working. So in that scenario we give the SK offloading, because all the time it is stick with the patient, even patient is sleeping, doing whatever, but until unless patient wore the footwear, this metatarsal bar or scooping is not working. So results are much inferior than even with the SK offloading or the indigenous techniques of the offloading the ulcer, or you can say it's based on the principles of just felted foam dressing only. So that is one. About the total contact cast and window, what we do to reduce the cost, generally in our patient, we generally just do with one cast or maximum two casts for the whole treatment duration. What we do, we don't use the plaster of Paris cast, we use the fiberglass cast, which is much stronger, much tougher. And before making that, we give a insole, that is a MCR insole, which I have shown you, and we make a window inside the MCR insole, and we just wrap this fiber cast and just mark it over the area of ulcer, and we just make a window. And what we do, we just observe the ulcer. We ask even the family members to observe the ulcer. If ulcer is clean, there is no infection, and there is no signs of any much of secretion. But in our country, when problem with the ulcers is there a lot of secretions are coming out, which is foul smelling, and which break the cast, which damages the cast. But if there is a window is made, the secretions has get down. So patients we ask just clean with the normal saline, and sometimes if the ulcer is very big and as is the long duration, we ask them to put a bit of growth factors also, especially the platelet derived growth factors, and we ask the patient to come every week. If it's an outstation patient, every 3 weeks, and if local patient, then every week, and they are coming. And sometimes if the patient cast is broken or damaged, then we cut it and divide it into 2 parts. Divide in 2 parts, and we will make it removal cast, and we repair it. By wall cast, just we divide it and make it, and we wrap by a crepe bandage. So that also works. So that reduces the cost. Cost of one total contact cast at my center is around 7,000 rupees for the total things, including everything, including even footwears that is there. So which is going.
One more additional point is it's absolutely contraindicated in peripheral vascular disease. It's you should not cast somebody who's got PVD and infection, because that exudate can be cleaned every day if you have a daily dressing change. So probably the 2 contraindications for putting a TCC is infection and peripheral vascular disease. And if it's a clean ulcer, probably a TCC would be a gold standard method.
In the up to the level of ABI 0.7, we are giving the total contact cast. Below that, we are not giving. Recommendation is up to 0.5. Below 0.5, you should not use at all. First, you increase the vascularity by any procedure, by plasty or by pedal bypass or by hybrid procedure. But we give a cast up to the ABI 0.7, because we have to check for vascularity, as fully agree with the Vijay, and infection of course. And infection there we don't give, and if really needed and we have to offload, then we give the Y-valve cast, by which you can observe regularly and you can open the dress. But that is not of much of use, as the purpose of giving a cast has been just lost.
Sir, for using the total contrast, reusing, we can use it to bowler iron, so patient can move here and there, so we can decrease the cost of the TCC also.
We are giving a MCR insole inside the cast, if I have shown you, so that you doesn't require this walking iron or walking heel. That was the principle, and we have measured the plantar pressures of these patients, and really there is a reduction of plantar pressures after giving a MCR inside the cast. That is the thing which we are practicing.
Excuse me, sir.
You said with TCC,
yes,
you distribute the pressure from.
Yes.
By giving a heel, you are.
No, sir, we are not giving a.
By giving a heel, you are not distributing throughout.
Yes.
So,
we are giving the full thickness, this MCR insole around the whole of the area of the plantar surface, not at the level of the heel. Yes.
Sir, I am
Question to
Dr.
Dr. Vijay. You just discarded the word mild, moderate and severe neuropathy, but at the same time you are classifying it as grade 1, grade 2, grade 3. Why?
No, that is something different. When we said grading, it was not neuropathy I graded. It was asymptomatic disabling neuropathy, and I put it according to the symptoms of the patient. I called it as grade 1 where there is no symptoms but neuropathy is present. Grade 2 was minor symptoms with 2 or more abnormalities. The last one was disabling neuropathy, severe symptoms with the same 2 abnormalities. I never said it was different grades of neuropathy. I said different grades of subjective pain sensation. So you got me wrong. So I said you cannot grade neuropathy according to the vibration perception threshold. But those 3 categories of Thomas Dick was all were the same thing, but the patient's perception. So what I was trying to tell you was, when the patient has no complaints in the feet, that is the time when you should go and examine.
Yes, the last question, because time is...
I have 2 questions, sir.
I have just one point to make. Actually, during Dr. Vijay's lecture, you were mentioning about the monofilament and the Indian validity. In fact, there was a study which was published, which was, I think, done in PGI, where they had studied nearly 1,000 patients and they had compared monofilament and tuning fork to VPT. They had taken VPT as the gold standards in Indian scenario. Many barefooted patients, not many, I think around 5 to 10% were barefooted, others were wearing Indian slippers. And they have validated that, saying that monofilament was equally predictable of neuropathy as like VPT. So I agree that there is positive data, but this is a huge study which has come up. So would your opinion change?
I don't know what Anil Bansali used. If he has used the original monofilament, then it's fine. But if he has not used the monofilament, and the guideline says, monofilament guideline says you should not use one monofilament more than 100 times. If you're prepared to take up the cost, then monofilament is a good option. But you can't use one monofilament for 1,000 patients. Only 100 patients, so then you have to factor in the cost. Anil Bansali is the one who did it, but I'm not sure what he used. So.
Okay, the last question.
I'm Dr. Ravi Kumar, foot care surgeon from Coimbatore, sir, Tamil Nadu. So one question to Dr. Vijay and another one to Dr. Goyal. Early neuropathy, the treatment modalities, how long we should stick on to the treatment, when to stop the treatment. We could see the prescriptions like methylcobalamin going for years together. So a guideline for treating early neuropathy, sir.
Once again, it's very difficult to define early neuropathy because there is no definition for early neuropathy. So the patient has got clinically neuropathy by examination. Then you should concentrate on your HbA1c, not on methylcobalamin. There is no study except some 1 or 2 studies talking about methylcobalamin. Whereas UKPDS and DCCT have all talked about neuropathy progression with HbA1c. So let's not be too much bothered about this methylcobalamin.
No, I'm not talking about the methylcobalamin.
So your HbA1c target is the most important. So primary prevention of neuropathy, secondary prevention of neuropathy, it's HbA1c, HbA1c, HbA1c.
Any other question?
So next one is to you, sir. So any ulcer more than 2 or 3 centimeters, we usually use skin grafting or flaps for healing. And of course, offloading is a must. Offloading procedure is a must. And the window dressing, will it not cause any edge effect on the ulcer, sir? That is one thing. Is there any other way to avoid the edge effect in the window, like foam and what you showed, the felt which was made into a window? That is one thing. The role of skin grafting onto the ulcers, which will heal the ulcer quite earlier, and the healing by scarring will cause re-ulceration often. So,
about the first skin grafting, on the plantar surface, skin grafting is a bit tedious job and generally doesn't stuck, especially in the pressure areas. On the great toe, first, third, fifth, empty and heel areas. These are the areas where the maximum pressure occurs. In that area, if ulcer is there, then the chances of skin grafting going to be successful will be very difficult and very less. In the midfoot ulcers, there might be good chances if you do a graft, then that will be successful because there is no pressures, not much of pressure. But on the pressure areas, especially again I repeat, grade 2, first, third, fifth empty heads and in heel areas, this skin graft is not going to be successful. One. Second, about the age effect. This is always discussed. Whenever you make a window and you scoop, there is a chance of age effect is there. But what we do, we cut the window much bigger, around more than around half centimeter to 1 centimeter than the ulcer area, bigger one. So there is generally not of much of age effect. But of course, there must be some studies to be done by measuring the plantar pressures. Is there any age effect or not? But we find with the good results. So that is the right concern of the age effect, that there is no doubt about it.
What advice you give for avoiding re-ulcerations?
About this, what we do, we ask the patient to continue with the total contact cast. At least the recommendation is 4 weeks, but we ask to continue to wear the cast for another 15 days. Even the ulcer is healed. And after that, we give the modified footwears. And if recurrence we call, if the same place ulcer recur within a period of 4 weeks, then we say recurrence. So in that situation, if it is there, then you have to treat as a new ulcer. But of course, you have to continue the offloading techniques minimum after even completion of healing 2 more weeks to strengthen, and after that give the modified footwears. That is our strategy.
We have come to end of this part of the discussion, and we should appreciate all the 3 speakers, give them a big hand, and we once again thank the organizing committee to giving us a chance to chair this session. Thank you,
sir. Thank you. You had a wonderful session. I have a pleasant task of memento giving. I request Dr. Shah to hand over a memento on behalf of the organizing committee to our speaker, Dr. Srijit Kumar and Dr. Bijay Vishwanathan. And I request Dr. Matthew Thomas to hand over a memento to Dr. Goel. Please, get the mementos. Srijit Kumar, yeah. Please. Next. Dr. Bijay Vishwanathan. Yeah, this is for Bijay Vishwanathan. And I request Dr. Bijay to hand over a memento to Dr. Shah and Dr. Goel to hand over a memento to Dr. Matthews. Dr. Matthews? Shah? Yeah. We have chairperson's memento also. Please. Dr. Shah. Thank you, sir. Thank you, everybody. We had a wonderful session 1 in the diabetes foot workshop, and with this knowledge of examination and offloading, we enter the session 2. That's the session on wound care management, diabetes foot infection, and establishing foot clinic. Dr. Ball is not here. Dr. Wadhwani, our chairperson, will be presenting his talk on wound care management, and Dr. Panshe and Dr. Abbas here for the next 2 topics. So I request our chairpersons, Dr. Shunil Wadhwani and Dr. Duffy, to come and start the session. I hand over the session to them. Welcome, sir. Dr. Wadhwani is a diabetologist, is a consulting physician at Surat and attached to Siddhi Hospital, who will be speaking today regarding wound care management. We present you Dr. Wadhwani.
Good morning, dear friends. This lecture was initially to be taken up by Dr. Arun Bal, but because of his ill health, he could not make it to come here. So I am taking it on his behalf. at the outset, I'm thankful to Dr. Arun Bal because he has provided me most of the slides which I'll be using today. Dear friends, this is the status of diabetic foot surgery or diabetic foot care in the 19th century era. Diabetic foot wounds are very severe and very bad, as you can see in these two pictures. About the incidence of diabetic foot wounds or ulcer in our country, 62 million diabetics are there in India. 124 million feet we have to take care of. 15% diabetics are prone to foot ulcers, and about 2 lakh amputations are done every year in India. People with diabetes are up to 40 times more likely to undergo a lower leg amputation. Every 30 seconds, a leg is lost due to diabetes in the world. 85% amputations can be prevented. This is very important, my dear friends. 85% of the amputations which are being done can be prevented if we take a few simple measures and if we have got knowledge about diabetic foot care. Well, most of the diabetic foot wounds are chronic wounds because there is failure or delay of healing. They are unresponsive to normal growth regulatory signals. They are associated with repeated trauma, poor perfusion, oxygenation, and or excessive inflammation. They are associated with systemic disorders, and genetic factors are also involved that makes these wounds chronic wounds. What are the factors in diabetics which retard healing? One is ischemia, another dry wound environment. Infections are there about which Dr. Sharad Pense is going to speak after this lecture. Foreign bodies sometimes that can lead to retarded healing, and anti-inflammatory therapy and nutritional deficiency, these can also be sometimes retarding the healing. Local factors which may affect wound healing are mechanical injury, infection, edema, ischemia or necrotic tissue, topical agents which are not to be used and are being used by few of our colleagues, ionizing radiation in some places, low oxygen tension, and foreign bodies. Now, other regional factors are arterial insufficiency, venous insufficiency, and neuropathy. In fact, vasculopathy, neuropathy, and infection is a triad which is leading to diabetic foot ulcer, which ultimately lead to amputation in many of the cases. Systemic factors which affect wound healing are inadequate perfusion, inflammation, nutritional factors, maybe other associated metabolic diseases, immunosuppression for whatsoever cause, connective tissue disorder associated, and smoking and tobacco chewing is very common in our country. That also leads to, that also affects wound healing in case of diabetic patients. What are different signs of infection? I hope Dr. Pense will be talking in detail about all this. Just a short note of that, that prolonged or unusual inflammation of erythema, if it is there, that we can consider it sign of infection. Yellow fibrin slough or necrotic tissue. Increased wound pain or tenderness, and heavy or malodorous exudate. If it is there, then we can consider that there is, these are sign of infection. For clinical assessment of wounds, we should see signs of infection, oxygen tension, ankle brachial index, size, depth, and location of wound, necrosis or presence of necrosis or granulation tissue, color, moisture, or suppleness. We should look at wound edges and odor or exudate if it is there. For management of diabetic foot wounds, we should remember time. T is for tissue management, I is for infection or inflammation control, M is for moisture control, and E is for edge or epidermal control. Let's start with tissue management. Removal of debridement is an important aspect for any wound management. Removal of necrotic, devitalized, or contaminated tissue. Necrotic tissue masks the infection and creates physical barrier to healing. It inhibits constituents of extracellular matrix and prevents granulation tissue formation. So, what type of debridement is to be done in a particular case is to be decided by size, position, and type of the wound, moisture level, pain management, time available, facilities available, and level of healthcare training. One is surgical or sharp debridement. This is the fastest way to remove debris and necrotic tissue. They are very selective. Minimal damage is there to the surrounding tissue. Here the person who's doing it, he knows what is to be removed and what is to be kept back. It releases cytokines that help wound repair, but this type of debridement needs training and needs infrastructure also. Then enzymatic debridement, this is most selective. Exogenous proteolytic enzymes are used to remove necrotic tissue. These work with endogenous enzymes to degrade the necrotic tissue. It may cause minor transient pain and discomfort. This method works best on any wound with a large amount of necrotic debris. Autolytic debridement is natural debridement. Phagocytic cells and proteolytic enzymes liquefy and separate necrotic tissue. Moist environment is necessary for autolytic debridement. It can result in significant wound exudate. It does not damage healthy tissue and requires minimal technology and training and minimal pain. Then biological debridement, use of larvae or maggots is done. Green bottlefly larvae are used. Useful in patients with thick slough. Limited availability of this modality is there, and it is not accepted by many patients, but it eradicates infection and smell. Mechanical debridement, this is a non-selective method, allowing a dressing to proceed from moist to dry, then manually removing the dressing causes a form of non-selective debridement, and many of us, those who are practicing in field of wound care, must be using this type of debridement day in and day out, and in most of the casualty, this type of dressing and debridement is being done. Significant discomfort and pain is there, and wound irrigation is unsuitable for granulating wounds. Maintenance debridement, it is an extended phase of debridement. It is required due to comorbidities. Single episode of debridement may not be sufficient. It offers distinct advantage in wound management, and enzymatic and autolytic debridement is very useful. Infection and inflammation control, I'll just touch this point, that is chronic wounds have higher bacterial burden. Contamination, colonization and infection should be differentiated. Production of signaling molecules which enables bacterial communications to adjust the wound environment, and biofilm, it is formation of microcolonies which secrete glycocalyx which prevents action of antimicrobials. When there is more bacterial load in a wound, then it definitely hinders the healing process, and risk of infection is decided by bacterial load and host resistance. Indications of infection, what indicates that infection is there in diabetic foot ulcer? If the ulcer base is yellow, if there is blue discoloration of surrounding tissue, fluctuation or crepitus is there, purulent exudate is there, sloughing of surrounding tissue is there, abscess, odor, or if there is delayed healing. What a general principle, initially one may use wide spectrum antibiotics, then one should take deep swab or tissue culture, and ulcer swabs at every follow-up visit should be taken. Gram-negative organisms from ulcer should not be considered insignificant. Blood culture should be done if systemic toxicity persists, and regular examination of the wound is needed. Antibiotic selection, later on we can decide as per culture findings, and debridement should be done to reduce bacterial load. For moisture control, essentially it is for exudate management. Excessive exudate and dry environment retards wound healing, and chronic wound exudate inhibits proliferation of cells. That's why moisture control is required. Exudate contains serine proteases which damages extracellular matrix and growth factors. A slide about dressings. Wound healing progresses most rapidly in an environment that is clean, moist, insulated and protected from trauma and bacterial invasion. Selection of a dressing is based on specific wound characteristics, that is the presence or absence of necrotic tissue, bacterial load, exudate volume and need for a bacterial barrier. Optimal dressing should be able to control exudate without desiccating the wound surface. It should act as a bacterial barrier. It should allow atraumatic removal with no dressing left in the wound and provide moisture vapor permeability sufficient to prevent overhydration of the wound and surrounding skin. What is the rationale for covering ulcer? It is to protect the wound from noxious stimuli, to prevent infestation with insects, to keep the wound warm, to protect the wound from mechanical trauma, and to reduce the risk of infection. edge or epidermal control. Undermining of edge is sign of infection or critical colonization. Hyperproliferation interferes with cellular migration, and there should be adequate perfusion. What are individual patient factors which delay wound healing? Social isolation or depression, alcohol misuse, smoking. As I already told in one of my previous slides, that smoking is very common in our country, and that causing vasculopathy that leads to added difficulties in healing of a wound in a diabetic patient. Unemployment or inability to work, poor glycemic control, and low self-esteem. Now, stem cells are also coming up as a factor to be used in case of wound healing. Leonardo da Vinci described the human foot as a masterpiece of engineering and a work of art. In 2005, a year-long campaign was being done that was put feet first, prevent amputations. This is this a diabetic foot successfully treated? Probably no. Well, dear friends, there is darkness, there is lack of knowledge, there is lack of facilities, but it is better to light a candle than to curse darkness. And when more and more candles will be burned, more and more people will get knowledge about the subject, probably it will give a new sunrise to the diabetic foot patient care. Amrita Institute in Kochi, they are doing courses. Dr. Arun Bal, under his guidance, many of the courses are being done. And Diabetic Foot Society of India, they have published 2 books. One is Guidelines and another is Handbook. Diabetic foot care needs a balanced teamwork. Well, I hope all of you will want that all of your diabetic patients should move like this, but not on one feet. It is in your hands, my friends, that you make life of your diabetic patient a desert or a valley of flowers. Thank you very much for your patient hearing.
Thank you, sir. Dr. Wadhwani has taken Dr. Bal's topic as a cricket coach going to the field when player is injured. He has covered very well, and will pass on to the next speaker. I request Dr. Ravi to introduce our distinguished speaker, Dr. Panshe.
Thank you. Our next speaker is Dr. Sharat Pense. I am very much privileged to sit here and introduce Dr. Sharat Pense, as he was my teacher during my training in podiatry in step-by-step project and encouraged me a lot to set up a foot clinic. He is a consultant diabetologist at Nagpur, India, and he had received many awards. In 1993, he was the outstanding young person in Maharashtra, and International Amputation Prevention Award he received in 1997. He was awarded Viswanathan Gold Medal Oration in 2008 and awarded Sam G.P. Moses Oration Gold Medal in 2009. He is an author of book Diabetic Foot, a Clinical Atlas, and he is the managing trustee of Dream Trust, a charitable trust gives insulin for the poor patients. He had many national as well as international publications. Over to you, sir.
Thank you, chairpersons. Yesterday, late evening, I was also requested to include some subject to cover Dr. Arun Bal, but I am very thankful to Dr. Wadhwani that he has taken this responsibility of delivering the talk on wound healing at a very short notice. So I have included a few more slides.
That's fine,
perhaps. Foot infection, as you know, is one of the most common and dreaded serious complication of diabetic foot, and is one of the commonest indication for hospitalization and often prolonged hospital stay. it's associated with very high morbidity and occasionally mortality as well, with ever dangling risk of lower limb amputation. And therefore, all of us should, whenever we are treating diabetic foot ulcer, the most important thing is to identify whether the ulcer is infected or not is extremely important. So prompt attention, appropriate diagnostic evaluation, and proper therapeutic strategies have to be chalked out. As you have heard, diabetic foot is a triple jeopardy. We have problem of neuropathy, ischemia, and on top of it, infection. And immune defects and biofilms compound the problem further. If you look at this slide, you'll appreciate that if the neuropathic ulcer or neuroischemic ulcer is not infected, the amputation rate, lower limb amputation rate is relatively low. But the moment it gets infected, in neuropathic ulcers, the lower limb amputation rate goes up to 30%, and in neuroischemic ulcers, if they are infected, it's a nightmare, as Vijay said, and the amputation rate can be as high as 95 to even 99%. So identifying infection and aggressive control of infection in any foot ulcer is of paramount importance. We classify infection into 3 grades: mild, moderate, and severe. The most important thing that you should remember is whether the patient has SIR or systemic inflammatory response. If patient has systemic inflammatory response, that's a bad prognostic sign. So if you identify infection, even if there is osteomyelitis with no SIR, it's not a severe infection. But if there is infection and if you notice SIR, which means patient is febrile or has hypothermia or has tachycardia or tachypnea or counts about 12,000 or below 4,000. These are systemic inflammatory response signs. So if they are present, you have to take very urgent steps and consider it a limb-threatening situation. Bacteriological diagnosis is important. Appropriate antibiotic therapy requires culture and sensitivity. Most of us are practicing superficial swab from the infection or ulcer. That is not the ideal method. You should obtain the culture and sensitivity specimen by curettage from the base of the ulcer, or during debridement ask your surgeon to take the best possible tissue which is deep, which gives correct yield, and you can specifically diagnose the pathogenic bacteria and not the contaminants. So we should avoid superficial swabs. Now clinically, diabetic foot infection, we divide this into 4 syndromes. There are 4 clinical syndromes. One is dorsal foot infection, plantar foot infection, heel pad infection, and infected perforating neuropathic ulcer or malperforans. We'll try to cover these 4 aspects. Dorsal foot infection, the characteristics of dorsal foot infection are, they are early recognized because they are on the dorsum. Everybody can look at his dorsum and identify. So the moment there is a redness or ulcer, patient reports to the doctor. So it's early recognized. It's always associated with extensive cellulitis. So even a small micro abscess will give full swelling of the foot because the skin is sliding on the dorsum, while plantar skin is totally attached to plantar tissue. It doesn't slide, while dorsal skin can be pinched. So the moment there is infection, suddenly you'll get a massive cellulitis. Infection spreads through lymphatics. And whenever you do debridement in dorsal foot infection, remember there is extensive skin necrosis. Look at this picture, dorsal foot infection, and extensive skin loss is a feature of dorsal foot. So even if you save the limb, you end up with a big defect. and invariably dorsal foot infection require skin grafting. Plantar foot infection is the most deadly and devastating. It's diagnosed very late because it's on the plantar area. It's the only soft tissue infection in the entire body which is on the weight bearing area. Nowhere else in the body there is infection which is on weight bearing, and this weight bearing area with no sensations or absent sensation leads to continuous ambulation despite abscess. So imagine a situation, patient has an abscess and he continues to walk for several days. Every walking step means the infection will spread through all the tendon sheets below the subcutaneous tissues, and the moment he reports to you, it has spread through all the compartments, or what one of our chairperson described, compartmental syndrome. So in plantar compartment, this is very deadly infection. Loss of protective sensation makes it treacherously silent, and because it is out of sight, it remains out of mind, and therefore very few patients can really detect plantar foot infection. It gets only recognized, it's nose that detects and not the eyes. It's the smell that detects plantar foot infection. Finally, plantar tissues are abundant in white tissue. They are plantar fascia, ligaments, tendons and fibrofatty tissues. These white tissue as compared to red tissue in the leg are relatively less vascular and can neither resist infection nor withstand ischemia for a long time. And therefore, you can see that compartmental syndrome, the patient has infected little toe from where it has entered the lateral plantar compartment and through the septa, and with the increasing compartmental pressure, infection spreads in the central compartment and lateral in the medial compartment, involving the entire foot and create a limb threatening situation. You can see here again infection has crossed all the borders and all the three compartments are now involved. Heel infection is most dangerous of all the infections. And remember, heel ulcers do not heal so easily, except when some of the techniques like TCC, I am very happy to see Goel doing wonderful work for heel ulcers. Otherwise, remember, heel ulcers rarely heal. Heel is the toughest part of the foot. If osteomyelitis occurs in calcaneum, then you take it from me, in majority it's going to be a below knee amputation. Deep infection in the heel can soon become a limb or even a life-threatening situation. Look at this patient with multiple fissures, which is very common in Indian subjects because of barefoot walking, wet areas, and on top of it, if they develop autonomic neuropathy, the fissures, and if these fissures get infected, take it from me, they have a heel pad infection. You can, when we took the X-ray, you can see the entire calcaneum is totally destroyed. This patient doesn't require any debridement but lower limb amputation, straight primary lower limb amputation. Heel pad infections are related. Therefore, we should always be very careful while treating our bedridden patients and prevent heel pad infections by putting some protective pillows or cushions to avoid pressure ulcers in old elderly bedridden patients. Because take it from me again, if they develop gangrene of the heel, whatever you are treating, it remains by the side and patient has to be attended for gangrene of the heel. Malperforance or penetrating neuropathic plantar ulcer, when it gets in, that's a garden variety of diabetic foot. Accounts for almost 30% of all foot lesions. And osteomyelitis is a characteristic feature of a deep perforating plantar ulcer when it gets infected. So always suspect osteomyelitis, or unless you rule out osteomyelitis, don't go ahead with any treatment modality in a deep plantar ulcer. And this is how the plantar ulcers get perforated deep and they get infected as well. Osteomyelitis is a characteristic feature of this, and it can be diagnosed by multiple discharging sinuses, sausage-like appearance, and if you probe these ulcers, you can almost feel the gritty feeling of touching the bone. You have to do an X-ray foot and then higher imaging techniques if required, and final you can diagnose by bone biopsy. This is a classical osteomyelitis you can see in a patient with deep plantar ulcer. This is a sausage toe, again an indicator, clinical indicator of osteomyelitis. You probe the ulcer, and if you reach the bone, you can take it from me that you are right in picking up the diagnosis of osteomyelitis. Now in these 2 slides, I will show you in the same patient, we did all the imaging techniques just for a teaching purpose. For example, patient presented with a swollen great toe with multiple sinuses, they were discharging foul smell. So clinically it was very obvious that patient has osteomyelitis. We did the probing and we did the X-ray, it showed classical osteomyelitis. Just for teaching purpose and in the same patient we did a nuclear scan, and you can see a hot spot, focal hyperemia with increased tracer uptake in the right grade toe. Another imaging technique to confirm the diagnosis. We did MRI of this same patient, and you can see low signal. All the toes you can see the signals, but great toe you don't see any signal. This is very characteristic T1 weighted image. While in this high signal stir images, you can see high signal in the same patient in the grade 2. So in the same patient you could use these techniques, but for practical purposes, if the X-ray is negative, clinically if you are suspecting osteomyelitis, you should use nuclear scan or MRI techniques to diagnose osteomyelitis when the X-ray is negative. And finally when we did the debridement, we removed the bones and did the bone biopsy, which also confirms the osteomyelitis. So in the same patient, for a teaching purpose, we used all the modalities to diagnose osteomyelitis. Apart from these 4 clinical syndromes, we have situations where there are infections which are extremely foul smelling, patient comes so late, they have limb threatening and life threatening situation. As you can see, patient has a Charcot foot, and on top of it, he has severely infected foot. And these are the clinical signs of bad prognosis when you are dealing with infected foot. If you see superficial bullae, or you see petechiae or ecchymosis, or when you palpate, if you feel a crepitus, if there is a tremendous foul smell, the patient is toxic, and on X-ray, if you see gas, these are the bad prognostic signs, and you should seriously think of doing a primary leg amputation rather than attempting several debridements and putting the patient at risk of death. Diabetic foot infections with long-standing infected lesions are always moribund. So for management purposes, we have to treat not only foot. So when you are treating a severe foot infection, never treat only foot. You have to treat patient as a whole. They are moribund, debilitated, toxic, and often septicemic. We need to do a thorough clinical and biochemical evaluation, and comorbidities have to be assessed, like cardiac functions, renal function, and nutritional status of the patient. And the principles of management are supportive treatment, glycemic control, antibiotic therapy, debridement. If they have associated peripheral vascular disease, that has to be evaluated first, and post-operative care of the wound, and to achieve closure of the wound. The antibiotic initial regime has to be typical, empirical, as Dr. Wadhwani said, and it can be made narrowed, specific, targeted after receiving the culture sensitivity report. And therefore, obtaining a good sample for culture and sensitivity is very important. For severe diabetic foot infection, parenteral broad spectrum antibiotics are recommended. And remember, when there are superficial infection, it's usually monomicrobial. When there are deep infection, it is usually polymicrobial. The surgery has to be definitive, radical debridement, partial foot amputation, or even primary leg amputation. If you look at this foot, you can see that the third toe is bluish. There are signs of infection here, and we can trace it that there is a erythema right up to instep. Now look at the way surgeon has carried out wonderful debridement. He has removed the third toe. He has removed the metatarsal as well. So while bold debridement is key to success, he has done a ray amputation, and now he has access to internal tissues. He removed all the necrotic tissue, and patient foot heals within 7 days. Offloading is extremely important. These are offloading required for infected foot. And these are the signs of worsening. If you see the signs of worsening, you should revise your decision and go in for more proximal amputation. As I said, if patient has peripheral vascular disease and infected foot, then the peripheral vascular disease should be treated first and debridement carried out later on. As you can see, this patient had peripheral vascular disease with infection. We did the angiography. We showed multiple blocks in superficial femoral artery. After angioplasty, you can see the debridement and red granulation tissue. So debridement has to be carried after revascularization. Now these are few new techniques. We use vacuum assisted closure, VAC therapy, for better wound healing, rapid wound healing. As you can see, this is the wound. This is the VAC therapy applied, and this is 2 weeks after VAC. This is 4 weeks after VAC, 6 weeks, and 8 weeks after VAC therapy. It works. It reduces the time of healing and gets a good granulation tissue, and particularly it forms a good base for future surgeries like skin grafting. You can see, can you appreciate? Yeah. The sterile larvae are available on prescription in Western countries, and they are particularly useful for infected ulcers with ischemia, where surgeon is scared to use his scalpel. So you can put the larvae, sterile larvae. They do all the debridement. They eat only the necrotic tissue, leaving the healthy tissue intact. In India, these larvae are not available on prescription, but they are available naturally. And but we see them often in our wounds, and for aesthetic reasons, we remove them. Britishers or in the developed world, they put the maggots in the wound, we remove the maggots. That's the only difference. And this is after maggots therapy, you get a good granulation tissue for healing. Remember, diabetes and infection, they enjoy each other. They enjoy at cost of patient. And therefore, we should take utmost care so that their enjoyment is not fulfilled and we save the patient's limb as well as at times life of the patient. It's very important. Thank you very much for the patient.
Thank you, Dr. Panche. I think that was a fantastic session on infection control. And now I request Dr. Wadhwani to introduce our last speaker, Dr. Abash.
Dr. Zulfikar Ali G. Abbas, he is consultant physician, endocrinologist and diabetologist in Muhimbili University of Health and Allied Sciences, Dar es Salaam, Tanzania, the largest in sub-Saharan Africa. He has been awarded an international fellowship by the CDC in 2002. He is current chair of the Pan-Africa Diabetic Foot Society Group. He is founder member of the International Diabetic Foot Study Group, and he has published extensively on the epidemiology and clinical importance of diabetic limb complications and established the largest surveillance system for diabetic limb complications in Africa. Over to you, Dr. Abbas.
Thank you very much.